slides. Sorry, I was just preparing for it and skipped ahead. It's so lovely for all of you to come and join me here on this. And thank you so much, Pain in Brain, for all this coordination, and also to Aspen Pharmacare for their sponsorship of this. I know what it's like after a busy working day to be dedicated enough to come to the CPD event as well. So I really do thank you all. And also I thank you all for all the work that you're doing out there, whether you're in hospital or whether you're in the community pharmacy setting, because these are really unprecedented times we're working in. So I think all healthcare professionals, even if you are not a pharmacist joining us here today, ought to be, thanked for just being on the front line of care in this setting. And I hope everybody is staying nice and safe. So I'm so pleased to be talking to you about my expert area, pain management. And as by background as a pharmacist, clinical pharmacist, this was an area that from Australia's perspective anyway, and later on I found out from a global perspective, how great an opportunity it is for pharmacists to really get up to date with this. And I think the other thing, aside from getting up to date with this, is what's our role and how can we actually play a role here? And often it's not been very well implemented. I think we've sort of tried to find our way in there, but it's been sometimes quite limited to just medication alone as our role. But you'll see, hopefully, the aim of this presentation is to show you that it really is beyond that and why that is. And hopefully this will empower you to learn more, and then to try and develop a greater footprint in this area of management of this disease state. So pain's always been seen in the past as a symptom, and that's often been difficult. Actually, we've treated it as a symptom for a very long time, and even some of our forefathers of like Louis Pasteur, who discovered penicillin, they knew that symptom management or fixing something wasn't the end of medicine, that it was more towards the prevention, really. So I love this quote from some of our forefathers of medicine. In talking about meditating over a disease, he never thought about finding the cure or the remedy or necessarily the fix, but instead how to prevent it from happening. And in pain world, because pain's always been just classified as a symptom, we've always been looking for the fix to fix that symptom and thinking that that would end there. And of course, over time, that's not been acceptable. It's not worked if we just limited it just to that. But that was because we did not understand pain. We didn't understand what it was. We actually didn't understand that. As I unpack the next few slides, you'll start to realize that it is not, in fact, just a symptom, and that it is actually and can be a disease in itself. So we'll explain what that means. But I think what we want to do is to put on your prevention glasses to go beyond the symptom relief. And that starts to become very fascinating. So just to set the scene of the impact of pain globally, interestingly, the statistics of 1 in 5 people in the world suffering chronic non-cancer pain, which is what we call persistent pain, not from a cancer origin, is reasonably similar across the world, around 1 in 5. In some countries, a little bit less. I think in some of the Asian countries, probably more like 1 in 4, but generally it hangs around the 1 in 5. And certainly in South African statistics, it's very similar. I think because we now know more about pain, more and more people are getting diagnosed each year. About 1 in 10 people are newly diagnosed. And interestingly, the most common symptomatic chronic condition, so people complaining of the symptom that lasts a long time chronically, is recurrent tension headaches. However, the disease state that causes the greatest disability, which is what we measure as years lived with disability, is chronic lower back pain. Now, if we just stop and just reflect for a moment, these are not conditions that necessarily you see in hospital settings. These are not tertiary admission things. Certainly, if you're getting an intervention done or a surgery done, or if the pain goes off the scales, perhaps, but generally, you're not necessarily visiting someone for very long in hospital who have been there because of chronic headaches. Maybe for a new presentation of an acute headache, yes, they want to get investigated, but not so much. So where else do these conditions therefore lie? They lie in the primary health setting. And unfortunately, if primary health is not well equipped, then there is a real poor access to services for these folk. And obviously people then try to seek out treatment by themselves or overuse the tertiary setting, who just simply can't handle the load. So I think it's important to appreciate, therefore, if pharmacists are sitting very much in the primary health setting, this is where we're seeing them. And I'm sure the pharmacists who are from community here will go, these are the people I see. And I suppose what I want to do is try and empower you on how we can manage these conditions going forward. Now, it's sometimes not so obvious, whereby there are hidden burdens of pain as well, correlated with primary diseases. So often, someone suffering diabetes type 2 will cruise on a high blood sugar level until they take notice of their diabetic neuropathy, which is now grabbing their attention. So then the suffering starts, because usually people sitting around a high blood sugar level may not even feel necessarily that they're on a high until years later, they're like, now I cannot walk, and the disability starts. So that's what I mean by the hidden. And it's usually the pain that starts to grab the attention and cause a disability and the suffering. So as you can see here, there are disease states that we must already be mindful of from the get-go that predisposes them to a high chance of chronic pain and disability. So up to 26% of type 2 HIV-associated neuropathic pain. You can see some of the broad range of numbers here. However, what's more interesting is the fact that it's not decreasing. In about a 16-year period, it has increased. I mean, this is phenomenal, 72% increase in neuropathic pain. And yet there are good treatments for it, which I will touch on slightly, although part 2, we will talk a bit more about what the PainWise program does in treatment. You'll see there even something as what we call simple as herpes zoster virus, which should be resolved once the virus goes, and yet it leads to chronicity at 48%, vastly because of early intervention. So I hope you're starting to go, gee, there's something I can do. There's something I can do. So a lot of it is about understanding the progression and reading ahead and early intervening, because these can all lead down the pathway of chronic pain. And neuropathic pain in itself, or mixed pain, and I'll talk a little bit more about the breakdown of the different pain states. But you can see there are other things, other comorbidities, multiple sclerosis, war victim, phantom limb from post-amputation pain. Now the usage of medications to treat one's symptom, for example, a headache, is now going to cause the pain in itself. And that's a tricky area where the wrong diagnoses of headaches potentially can lead to overuse of medications. Approximately 15 days or more of medication overuse will lead to medication overuse headaches. Opioid-induced disorders that can increase pain, and even cannabis use disorders that can increase pain. Of course, we're talking about excessive levels here, but we call that hyperalgesia, which over time, when you're in the chronic pain space like I am, these present quite commonly, and they are very much in the areas of where pharmacists can monitor and can educate on as well. So how do we feel pain? And this is, once upon a time, we thought it was quite straightforward until we respected the fact that the body actually plays as one whole piece. At first, as I mentioned, we looked at it as a symptom. So you can see here, here's a nail that's actually caused a stimulation process, a pressure response in our nociceptors, and it's actually started some messages happening up the chain of our nervous system. So that's what we call transduction, whereby we have fast fibers, slow fibers, and basically it triggers and stimulates an electrical impulse. It is not pain at this point. Noci means pressure in Greek. So it's a pressure response that's occurred and triggered these messages that have gone up chain here, as I said. Once upon a time, we thought that this was pain, but it's actually not. And if we played this in slow motion, this person is not feeling pain right now. However, what happens next is this electrical transmission process that goes into the dorsal horn, which is junctions. These are junctions where the primary afferent nerve system hands over messages to what we call the secondary order nerve system as well. And there, at these junction points are where gates, theoretical gate, and you may remember the gate theory from university, but these are gates where they do open and shut, to put it simply. So if they let messages up the chain, again, not feeling pain, just a lot of electrical impulse. Sorry, I keep pressing the wrong buttons here. In fact, at this junction point, talking about the gates, these gates are very able to modulate as well how much information that goes up. They can be interrupted. There are some interventional devices that can interrupt this signal. There are sensory things we can do that will interrupt this signal. If you know things like the TENS machine that creates a secondary stimulation in another area, that can interrupt the signals. So we call that modulation. So that means that pain can be changed, in fact, through other means. And then finally, the impulse reaches the electrical impulse, and all the neurochemicals start to reach the brain. And there's peripheral chemicals happening as well. There's inflammatory chemicals happening as well that's actually sharing that message on. Finally, it reaches the brain, and the brain looks at this message, and it looks at whether it's going to alert you or not. So the brain, of course, is very complex, and it doesn't just look at one piece of information. It looks into the brain, and it looks at, have I seen this before? And so they'll look at, what am I feeling at this moment, which is our limbic. Am I feeling threat or not? It's looking at the somatosensory system, meaning that it's locating it. Where is it coming from? Oh, it's my finger. Where's my finger? Oh, my finger's on a nail. So it's starting to interpret all of this in our cognitive department, which is where our logic centers are. So what happens over time is then it gives you a message of pain if it wants you to retreat. So our protective system is incredibly unique in that it then tells you, okay, there's pain, it's a nail. If you keep going on this hammer, the nail's going to get in your hand, so then you retreat. So that's your retraction process and your protective process. Now, that is an incredibly important response for our survival. If we did not have this response, we wouldn't last very long on the earth, which is why I always tell my patients that, in fact, pain is good. you can imagine when I say, but pain is great, they start to feel this, see, this is great. But in effect, when you appreciate it from a mechanistic point of view, it is great. From an acute pain point of view, it's very much needed. Now, before I talk about how pain hangs around and becomes chronic, we also have in our system a remarkable process, which is a descending modulation process that comes pretty much from our brain, and it releases neurochemicals that can dampen this pathway, that can provide neurochemicals that can reduce the intensity of this pathway, or there are neurochemicals that can be this inhibition as such. And those neurochemicals, you will know, they are noradrenaline, they are our own endorphins, which morphine mimics, they are our own serotonins, and even our dopamines, and even oxytocin. So there's a whole heap of really nutritious, really nourishing neurochemicals that can help with the descending inhibition of pain. Those are very important. However, whether they do release sufficiently or not is obviously, part of whether the person is able to reduce pain by his own inhibition system within or not, or whether you stimulate that through other means, whether it's through pharmacological means, like through antidepressants, which is now why we do see the use of antidepressants as a pain modulation drug, as opposed to always just for depression. You will probably see that in some of your settings. So that's working on the descending inhibition system, or whether we use opioids within reason to mimic our own endorphins, which are very, very short half-life. Our own endorphins is so powerful, about 100 times more powerful than the synthetic morphine. However, the half-life is just so short. So therefore, that descending modulation process, we hope it works, and then pain resolves. Now, it's not, that would be nice in a non-complex situation. But as you know, the body can be quite complex. And even the brain system looks at all this memory of pain, where it's at, the traumas of pain, and all the above. And what that can create is, in some folk, and we are researching, what happens within individuals, whether there's genetic dispositions, we can find that this system, this communication pathway, can become dysfunctional over time in some people, who then progress to chronic pain. And that is where the healing for perhaps of this injury has gone, and yet this system remains what we call switched on. And the circulating system is then what we call a dysfunctional system. And so we've got this acute pain, as I've said before, that it's fast, it should be short, it should resolve. And it is important, and we'll talk about some disease states that can contribute to this area. And we hope it just heals, and it's a quick, symptomatic management, and then we're done after the resolution of inflammation and healing. However, should people go into persistent pain, which becomes quite complex, this then lasts longer, healing's occurred, pain continues despite healing. Of course, that used to bamboozle us. But now that we understand that we're still gaining, obviously, an understanding of all the complex mechanisms, but in some way, we've got better understanding that it is this dysfunctional or maladapted system. So in persistent pain world, we talk about dysfunction, we talk about maladaptation, we talk about modulation and change. Though, because we are dealing with the brain, what is very hopeful is that we can try to use many methods to modulate, in some cases, modulate completely back again. In other instances, depending on the pain condition, modulate to a degree where suffering is not as high in the disability scale. So we look at persistent pain in a very different way. We see it as, in fact, a disorder. or a disease in its own right, which is why I started off saying that it's no longer just a symptom alone when it becomes persistent pain, that it becomes a symptom, a disease in its own right. And I think this is the part where in the world of medicine, where we come from a very biomedical system, where we do rely highly on fixes, and we do rely highly traditionally, that is, on MRIs to tell us what's wrong, that this is not where your MRI is going to help you. And that's where patients have become really confused and what we call invalidated by the fact that, well, my healthcare professional said to me that my MRI is clear, but I swear to God, I'm still in pain. And so they start to feel like they're, hypochondriacs. Sadly, we may even contribute to that. Definitely in times past, when we did not understand this well enough, we did not give them answers. And now that pain understanding is advanced a lot more, we can now make sense of it. And therefore, treatment has to be a lot more comprehensive. It has to be more complex in treatment. It's not as simple as just increasing one drug and keep going and keep going. And in fact, our body has, it kicks back on one modality of treatment. Any modality of treatment, if it's just excessively used for persistent pain, it can be a drug, it can be exercise, it can even be good things, diet, any of those that's done excessively because of the dysfunction of the system and the maladaptation of it, it will kick back on that. So I've had patients, in fact, I had one the other day who came and said, look, to help with my persistent pain, I just thought that I would keep strengthening and conditioning myself. And in fact, the body went, and it went into a whole, it would not tolerate it. And it was so sensitive that, even the thought of walking, he could not do. And he was so debilitated. Now, you're not going to be able to explain that with an MRI machine, but truly you can explain that more through the proper context of history taking and a proper understanding of how one's central nervous system, that of the brain, that of the central nervous system, a nerve function, can actually maladapt so profoundly. So I hope that sort of starts to provide some background on this very fascinating area of neuroscience, actually, in pain management, rather than just a peripheral science that is only isolated to musculoskeletal science. So it goes beyond that. So back in the primary health setting and the more everyday setting, of course, things like acute pain that you see would be tissue injury, inflammation being a very huge part of that. You'll see conditions like headaches. It can be acute tension headache, but of course, as things progress, headaches can also become chronic. Pain related to colds and flus. These are sort of everyday things that do bring people to the pharmacy. Sinusitis can be acute, but repeated recurrent can become also chronic, where the layers become very sensitized as well. Neck and back pain can be acute through a strain activity, or it can also progress to chronicity. Muscle strains and sprains, period pain, endometriosis can follow, and even dental pain. Dental pain usually would be quite acute. However, if there are other nerve involvements, or even other psychosomatic, psychosocial involvements, that can end up escalating. So the key message, in fact, with acute pain is to be very wary of taking good history so that patients whom you can see can progress to chronic pain, that they can be early treated, treat it well, treat it quickly, given the literacy, and to stop or mitigate that process if possible. And that's only possible through our own understanding of what can happen. Now, I don't have time to go into some of the predictors that we now know can predict from acute to persistent pain, something what we call yellow flags. But that's what we cover in some of our other training. But suffice to say that the earlier, the better to intervene if possible. Otherwise, sometimes you can end up with this chronic progressed persistent pain state. We use the names interchangeably. Some people like to use chronic, some people like to use persistent pain. In Australia, we were more favouring persistent pain, slightly to make it sound more hopeful. Either way, it continues on. Oops, sorry. So it is a progression related to sometimes tissue injury, but has healed. Inflammation is part of the process, but there is this disease process and dysfunction happening as well. And it's not to say that there aren't, pathology happening here. In persistent pain conditions, there can be pathology happening. So autoimmune inflammation going on, or bone that is degrading. There can be this kind of, musculoskeletal background happening. But what you get is a very sensitive neighborhood, I call it. So in this case, there's still a joint on joint that's degrading. However, you've also got the musculoskeletal tissue that becomes inflamed and sensitive over time, and that becomes chronic. And then you get the behavior of chronicity happening as well, the fear, the protection, the overuse of other joints, the shuffling. So then that's how it becomes a disease. It becomes very much part of what we call the psychosocial behavior of the patient as well. If they're not heard, they can start to catastrophize as well. Fibromyalgia is, I'm sure you'll see that in your setting, but that is where MRIs don't show anything. X-rays sometimes show, sometimes not, but they usually show comorbid things like osteoarthritis that might be primary. But fibromyalgia is very much mind-body dysfunction. And that's a hard one because for a long time, we didn't believe the fibromyalgia mechanism. And you get these people with very generalized, very random pain that 1 minute happens here, next minute happens there. And there's no sort of pattern necessarily to it. The thought of pain, the thought of a trauma event can actually exacerbate the sensitivity that comes on. And that's really very much in that dysfunctional pain process as well. And we haven't even talked about secondary depression and anxiety and sleep and fatigue that comes on. So that's why it becomes very much a disease state. Post-stroke neuralgia, phantom limb pain, these are all chronic conditions related to pain. Complex regional pain syndrome. Now, this is a very interesting complex pain whereby an injury has healed and yet the limb can start to change in its presentation. Color changes, swelling that can be quite unilateral. Peripheral neuropathy, now this is a preventative, one that is preventative perhaps in type 2 diabetes, to be really honest, or at least delayed for a very long time. But we're now seeing that if patients in type 2 diabetes are well managed, that in fact they do not have to progress into peripheral neuropathy as we once thought that, oh, that's the inevitable end. But actually, it doesn't have to be. This is one, depending on the primary condition of what causes the peripheral neuropathy. Something like type 2 diabetes, yes, you can prevent. Potentially something like maybe a nerve injury or severance, maybe a little bit harder. Chemotherapy induced, perhaps a little bit harder, but we can still definitely treat it quite well. And I'll discuss some of that treatment. So you can see by now that even if we just talk about, without even going to all the psychosocial things, even if we just talk about pain pathophysiology and the classifications of different pain states, you can get the nociceptive pain, you can get somatic on the joint, you can get visceral in the organ. You can get neuropathic pain where you get damage of the nerves. It can be peripheral, or it can be central, like strokes. You can get this maladapted, or what we call central sensitization, which is, this is where the maladaptation and the dysfunction, this used to be called dysfunctional pain, but it kind of sounded quite, quite derogatory. So they renamed that as central sensitization, which is that heightened, maladapted central nervous system and brain upregulated pain response. And they also looked at this new terminology called nociplastic, whereby it's not nociceptive, but it's plastic, meaning it's changed. The nociceptors have become sensitive, so it's changed, it's modulated, and therefore the word plastic. And when you hear the word plastic, you immediately think of neuroplastic. You think of the brain and how that has in fact changed. But it's very hopeful in this space, even though it's not easy necessarily to treat. There can be reversals that can happen here. And I think as a pharmacist, that's where, when I started to understand pain, and now working in it all day, every day now for the last 15 years, we are influencing the change. Sometimes as simple as literacy, sometimes as simple as compliance of breathing, of taking their medications in the right way, of the right medications, we can start to influence this change quite holistically. And of course, life is never simple. So you can get this mixture that's happening. Now, while it may, and I hope it's not too complex, but as a pharmacist, when you look at case managing this, and when you look at putting treatment to this, in fact, not just as a pharmacist, as anyone, what we try and do, and we will certainly unpack this more and teach this more, but just to let you know, what we try and do is we try to, first of all, with the patient assessment, look at what types of pain they're presenting. What's here, and what's here. Sometimes there's a little bit in each circle. Then what we try and do to make sure treatment is meaningful and not just a big gunfire, oh, well, here's a painkiller that's somehow landing somewhere in one of these circles, is we try and meaningfully put treatment in each of these, depending on where their pain condition is, and we synergize. So if it's a somatic, osteoarthritis process, we might look at certainly, potentially anti-inflammatory. So we might look at paracetamol. We might look potentially, in some cases, short-term opioids, So that might fit in that circle. But if they do have nerve damage as well as their knee osteoarthritis, we might look at treatment here as well, so that we're not just singularly treating here, but we might provide a little bit of pregabalin, or we might do some topical treatments in this area that can influence the neurofibers. In this area, if they've also got fibromyalgia on top of it, which is where it fits in here, then we might look at less medication treatment and provide more comprehensive psychotherapy, for example, of course, with good literacy as to why. So then we're starting to treat it like a disease, not just a symptom alone. I hope that sort of starts to give you a really good idea of how you can start to properly formulate pain treatment. It is a bit of an art, but it's a real joy when you get it right, because you're not just doing a rolling ball effect and hope that it hits some pins down, which traditionally is what we used to do. We just used to give an opioids and go, well, let's increase the dose and we hope it hits one of these symptoms that you're complaining about, which is not really rational treatment now that we know how to do better. Now, of course, these are some of the progressions of pain, or not progressions, and where pharmacists can intervene. Of course, acute pain, as I said, we hope for healing, and then we hope that there's no more pain. However, in some pain states, this little purple circle shows that if the pharmacist can intervene early enough, we can help to reduce the spread or progression to chronic pain, and acute can become chronic in this way, or something starts very insidious like low back pain. Oh, I just kind of, managed it myself, or weight gain starts to impact, and then it insidiously progresses. Insidious means it just creeps at you. One flare-up, two flare-ups, three flare-ups. The patient becomes more sedentary, they become more fearful, and then it leads to chronic maladaptive changes. Again, this is where pharmacists, probably this circle should sit earlier on, but again, that's where pharmacists can intervene if you're already seeing, the story playing out there. And as I said before, we did look at it from very much a pathophysiological effect, the mechanism, the neurochemicals, but to put it into a proper, disease state and what really can impact on disease, whether you're talking about a cardiovascular disease or whether you're talking about diabetes as a disease, pain now very much we know sits in here. So we've been talking a bit on the bio and the pathology and all that, but as I showed you before with how the brain interprets and perceives pain, we also start to impact on other areas that impacts the brain, like depression, anxiety, other neurochemicals in there, like guilt, like stress, like identity, like emotion. So it's correlated. And the depression is high. And we do see suicides, unfortunately, that can occur, which is usually quite underreported. And then not forgetting the social aspect of this is the interference, this is the suffering, this is the part where the disability starts to impact, whether it's their own livelihood, whether it's their family, whether it's their finances. And you can imagine that all of this starts to really shake the fabric of a person as such. So in times past, you can see that because we treated it as a symptom, we completely missed the boat on it and really didn't do patients any good. But of course, that was the old understanding. And that's why I think I sort of did label the fact that this is a changing landscape now, very much so. Now, as a pharmacist, sure, we sit maybe a little bit in this treatment area, but I'm sure we're all aware that we see patients and we talk to them and we listen to them and we educate them. That very easily can impact these areas because so many patients, and I hope you've had this experience, and I'm sure you all have, especially the dedicated ones here coming up to work tonight. I'm sure you've talked to patients before and they've said, oh, I feel so much better just talking to you. Now, patients don't say that just to please you. Some do, but they say that because their neurochemicals has enabled them to say that. They've had a neurochemical response. They've had serotonin, they've had dopamine. And so they're saying that. And so you yourself can truly impact on that relationship, what we call the therapeutic relationship, which is a lovely, very lovely, nourishing placebo that you can induce through education, through compliance, through monitoring. So our life as pharmacists in pain is absolutely not just focused on this, but it can certainly progress to these other areas as well. What we do is to prevent this vicious cycle. We do not want patients to enter this terrible vicious cycle where truly there's more and more disability as they cycle in. They reduce movement, they're scared, they avoid doing things, they start to have unhelpful thoughts and emotions. They sometimes get no answers, anxiety, agitation, frustration builds up. Fear is one of the biggest drivers of this cycle. When they don't understand, they fear. And fear in the limbic system will increase the perception of pain. And that's why when patients say, oh my gosh, I feel so better now that I understand it, that's their fear response reducing and their limbic system reducing their pain response. So we have influence very strongly on that. And of course, it increases pain sensitization. And this just shows, obviously, the other psychosocial effects that I was talking about as well. And I think you know this merry-go-round very well indeed. And that will also upregulate that pain sensitivity response. So us as pharmacists, you know, we sit very much in this process. And what we try to help patients to understand is this very much individualized management response, if we can. Pain is subjective. So if I've got pain right now, you can't feel my pain. So it is, you do rely on the patient's self-report for the most accurate response of pain. So you can't just rely on an MRI. You've got to listen to the patient and then sometimes put a few other clues together. So the patient, in fact, sits in the middle if we're going to get anywhere with pain management. You put the patient outside that cycle and you're not going to be able to assess well, and you're not going to be able to find out what's actually wrong with them or what their pain is from. We also want to fit them within the circle so that they start to be part of their own solution. And this is what we call self-management. The word self-care is circulating around the globe right now because of COVID and people are being more aware of it. But I find that a lot of the applications of what we've been doing in persistent pain has been so easy to apply into the COVID management because we've always had to self-manage despite pain in some of these patients. And I will say that some of the studies that are showing with COVID and long COVID, so we're going to get into that acquired process, the maladaptive process of long COVID, more and more we are going to need to apply all these principles that I've just briefly talked about. And more we're going to have to enable the patient to self-manage because a health system cannot do this. It cannot afford to do this because really they're only going to see a health professional for a very short amount of time, whereas they're with themselves and their chronic pain for a very long time in the day. So they have to know how to self-manage. And so in the pain world, what we are trying to teach them is, number one, to understand it. Number two, to have the strategies to go through. And I suppose now towards the last little part of the hour, I want to sort of show you perhaps where pharmacists can sit in this journey. So many areas, and you're not all going to be in all these areas, but I'd like to show you some of the roles we can play. And, you know, it's almost as if within each category, again, there is so much more. So this is almost peeling back a Pandora's box here. We'll open the box and then there's more to go, and open it some more and there's more to go, just like the Russian dolls that you kind of keep finding these little Russian dolls in there. So this is in fact the extensive role of pharmacists, and you pick where you want to play. So obviously from a hospital point of view, and certainly more in an acute setting, definitely, of where the hospital may play, you'll have medication reconciling, you'll be on the ward doing inpatient services, and, you know, looking at pre-surgical pain relief perhaps and other medication reviews. What's really important here, I find, you're under the protection of the hospital a lot of times, you know, because you're just under a very protective one roof. Where the pharmacist plays a huge role here is in, I feel, the discharge counselling for pain management, because often the transition from hospital to then outside of that in the community or in the home is usually poorly done. And this is where there's a lot of errors that can happen, and this is where many things can go wrong. So there's been studies to show that if patients leave the hospital, so just to give an example, if patients leave the hospital with opioids, they are likely to continue to use opioids in a more escalating way. However, if the patient's pain was well managed in hospital and they leave without pain management, or with very, very little, with some really good prescribed boundaries that is communicated to community or to home or to the doctor, they have a lesser chance of going into that poor route of medication overuse in terms of just from the opioid point of view. So I think there, the pharmacists, if one was really understanding pain management and the progression of what can happen, can intersect very well. And it's a critical role there, I feel, to intersect well. In Australia, we are just starting to look at more and more what we call opioid stewardship that, you know, can impact further on this area. In the home setting, following on, post-discharge follow-up is really important if your service allows that. Rehabilitation care is also very important should those need to go on to medication use a little bit beyond. The health literacy is so important here as to what to do when they get home, what to do with the medications, when they're appropriate, when to stop, and being very prescribed about it. So I find with patients, if you say, well, this is only going to be short term, they don't know how long short term is. But if you say, look, post-operation, I expect that you would only need to have this for 14 days and give some idea of time frame. Of course, there's flexibilities. And if after 14 days, you know, you've still needed it, you need to go and see the doctor. So having some really prescribed milestones is helpful. Otherwise, they just go and get another script and another script, or they self-manage, or they save it, and then, you know, that becomes a compounding issue. So I think it's very important, the literacy and the expectation of what it's going to do. Because sometimes some people will take pain relief and they're very fearful and scared to move, and they'll take pain relief to have almost 100% resolution. And if the pain relief doesn't give them 100% resolution, they won't do their physio rehab. So again, the expectation of, you know, this drug is really only going to take the edge off maybe about 30%. But don't fear, it'll get better when you do move. So that's important to come, you know, in with the expectation of, and if it's coming from a pharmacist who is a pain, you know, or who's a medication expert, it's going to be better received than if it comes from perhaps a physio potentially, because, you know, the motivation might be a little bit different. So I think that is so simple, but so important to set expectations on. Wow, in the community, you can see where your role can be as well. You know, medication counselling, early identification of some of these potential chronic cases that can eventuate, over-the-counter usage, people seeking for solutions perhaps where they shouldn't be using the over-the-counter. And that's where a lot of education can happen. Perhaps pre-surgical counselling if they're going to one, perhaps while they're in rehab. And doing all of this will help to prevent hospitalisation in some cases, collaborating with the GP. And as pharmacists, you know, traditionally our role is to sometimes mix around with some of our formulations. We do, I don't know what the South African climate is on compounding medications, but certainly in the pain field, we do compound some medications, particularly effective for topical use to reduce the oral load. We have found peripheral nerve fibers to be very noisy in chronic pain states, to be very active, and sometimes localizing treatment rather than taking a tablet that's more generalized can be very, very effective, both commercially available, like diclofenac, but then sometimes we increase the strengths of that or use compounds like ketoprofen or ketoprofen for compounding. Again, it depends on your country's legislation for that, but we have certainly found that very effective. And to some extent, off-label prescribing, using antidepressants for pain, for example, using pregabalin, which is an anticonvulsant for pain, neuropathic pain, for example. And of course, in community, that's where our interdisciplinary care navigation should come in as well, because that is where we also sit with physios and, might be able to access, that can happen within a hospital setting, but that can also hopefully happen in a community setting. Again, this does depend on funding, situations within countries, but I suppose if a patient was of some financial means, you can collaborate with interdisciplinary networks and inter-refer that as well. Certainly that's what we try and do in Australia, and some of our funding mechanisms do allow that. But in a hospital setting, it's probably a little bit more cohesive as well. But of course, the hospital is not always where chronic cases will necessarily live. The whole idea with all this management is to try and prevent and to risk manage so that it prevents a hospitalisation because of pain. And even in that setting, the importance of drug monitoring. Where I do find that's helpful here, which I didn't add here, but it's come to my memory, sometimes if you do know the patient well here and you are collaborating with the GP, sometimes patients do need to present for escalating pain. And what we do with the GP is we provide the patient with a pain plan so that when they reach an emergency setting, the poor old doctor at the emergency is not going, oh my goodness, how do I treat chronic pain because I'm in an acute care setting? But if they have some sort of letter or planning by the primary healthcare team, it goes a long way to have the patient better represented. And it goes a long way to have the emergency consultant have some background and know how to treat someone who's of a chronic setting having perhaps an acute flare-up. Because even though your system becomes dysfunctional and maladapted, it doesn't mean that you still can't have an acute flare-up where the threshold of pain has exceeded as such. So as you can see, medicines is only one part of the treatment, and there are so many other things that can be done. And this really just reiterates the pictures that I showed you of what pharmacists can do and how we can implement services. So one thing is to learn about what we can do. The other thing is to go, well, how do we do what we now know we can do? So implementing services, whether it's in a hospital setting, whether you want to, do medication reviews, or whether you want to do what we call disease state care plans. These are things that our program teaches. We now have to help pharmacists to have material and resources to implement these potential services. In a community setting here, we do medication reviews, we do disease state care plans so that patients have a plan. Having a plan is really important for any disease state, and chronic pain has always been forgotten about having a plan. So having a holistic and comprehensive plan is potentially a chargeable fee-for-service exercise as well if you are in a community setting. Certainly patients over here are paying sometimes small fees for the pharmacist to do a plan. Again, I'm not sure if your setting allows that, but certainly in some private settings that can occur, and that starts to give pharmacists that opportunity. Risk assessment, early identification, and pharmacists can go the extra step as well to providing group-based self-management education. These are the dream things we can do, and they are certainly, and we've designed programs to enable this. So I run self-management programs in pain management, and patients come and they attend it, because you can imagine a lot of self-management education can be quite repeated. You say it to one person, you can say the same thing to the next person. So doing it in a group format makes it scalable and makes it resource friendly from a cost perspective. Cultivating that therapeutic relationship, which is a very strong placebo. Placebo means positive effects, yeah, not necessarily the oh, let's fool you to make you feel better. It's actually a very profound trust response that comes. Translating, of course, evidence into practice. So all the pathophysiology that's set with big neurochemical names and it's not explained to the patient, then it becomes, non-translatable and not able to be clinically used. So not forgetting that we sit as interdisciplinary as well. So we can navigate to other healthcare professionals. We can create network strength by knowing who around us can help us out as well. How we can tell them what we do, because often pharmacists will refer out as well. Certainly that's the case here, but I always say, well, what's coming back? Who knows what you do? Who knows what you're interested in? So you need to go out and let them know. So that's what role optimization is about. Not being silo in our practice. If you now have an interest in pain management, let your community doctor know, let your community physiotherapist know. Of course, you can do health advocacy for the patient. Once you start with literacy, it's already a big one on patient advocacy. And of course, if you are higher up in the chain and you can influence on policy, then it's so important to start to change pain from being a symptom management to a more disease state management as well. So I think I've gone 3 minutes over, but I think the first part hopefully gives you a good understanding of where the climate of pain is yet, hopefully how much you can do in this space, and how we can then implement it. Obviously, that's the next part, and how programs can help you learn more on that. But I'll just stop and pass it over to Kathlo there, and you can give me some questions if there are any.
Goodness me. I so wish I was a pharmacist with all the knowledge and the practical skills that you've shared with us today. I would just implement everything for the betterment of the community and the people rather that we see in our communities, to make sure that we help them with the pain that really brings a lot of suffering, that interferes with activities of daily living, so on and so forth. All right, so I just opened a platform to everyone in attendance, that please feel free to ask questions in the chat, and I'll just forward them to Joyce. But I do have quite a number of questions from myself here, but let's rather attend to the questions from our audience first, and then we'll end off with mine if we have questions. All right, there's a question from Dasha, I believe. I'd really believe that I'm pronouncing your name quite well here. So one question says, I would like to know why endometriosis pain is considered as acute. Just curious to know. All right, so I think, just to paraphrase here, they just want to know why endometriosis pain is considered as an acute form of pain. Any ideas?
Yeah, well, I mean, look, typically endometriosis as a condition is not actually in the category of chronic, of acute pain. It can have acute flare-ups and it can present acutely, but it is a disease. It is a condition. It is where it has to be treated as a condition. Typically, it starts with pelvic pain. Patients come in, they seek sort of over-the-counter help. If they seek a lot of frequent over-the-counter help for pelvic pain that's sort of undiagnosed, especially the young women, you really need to forward them into, good gynecological diagnoses to see if they do have endometriosis or not, because they do need one good chronic treatment, but and typically amitriptyline, for example, is used to help to desensitize the pain. However, if they do, need intervention treatments, sometimes that's what they do need, because otherwise you get a lot of scar tissuing happening, in the region of the pelvis and in that whole over region. So truly, I wouldn't classify it as if it was diagnosed as a disease, it's a condition, it's a chronic condition that needs help. But we don't want it to turn chronic in its pain, though. So we want to manage the sensitivity of the pain. It can, where the confusion I think comes in is, say, for example, when they get their periods in their monthly cycle, they can have acute pain then, and very severely sometimes. And you hope that treatments like amitriptyline, for example, in the background, which I believe is first-line treatment, can help to reduce the threshold of acute pain in their monthly cycle. So acute pain can present with the triggers of the monthly cycle. Sometimes they use oral contraceptives, again, to reduce the proliferation of the layers. But yeah, sometimes we get chronic stuff and you can go acute on chronic, it's not just so simple as just, oh, that's chronic, so therefore you don't get acute pain. I hope that satisfies that. But this is a big for pharmacists, because I see a lot of, I see and I have seen and I continue to see a lot of medication overuse right here. So Dasha, I really thank you for this question, because I do see a lot of medication overuse in the pelvic pain young women cohort.
Nice. Thank you so much, Dasha, for that question. And thank you so much, Joyce, for your comprehensive response to that question. It really is a common phenomenon that most women experience in this country, but it's quite a tricky one, because as it stands, there isn't like a solid guideline on how to go about assessing and even treating. But I really like how you outlined that it's not as simple as acute or chronic, but in some instances, it could be acute on chronic. So thank you so much for outlining that. All right, we have another question here from Tegan. Hi, Tegan. So the question goes as follows, Joyce. Do you think language barriers create a misunderstanding and extra challenges to creating that psychosocial support structure you've mentioned? This may be relevant in our setting more than yours. So before you answer that question, just to give you a background here to our context, we have 11 official languages, and this is just official languages here in South Africa. So, and we have about, so in each and every province, I would assume that there is more than 3 or 4 languages that are spoken in a specific area. So I just wanted to give you that context before you answer the question. So you can go for it.
Yeah, I do appreciate the language barriers, and I very much appreciate also the cultures. As you can see, I'm of Asian descent. So I get languages and I understand cultures, and I come actually, I was born in Singapore, where it's a very, very multicultural area of so many languages, right? Even in the Chinese area, there's so many dialects, which is probably what you're saying in terms of the official and the non-official dialects, right? That happens with tribes and areas. So one thing that's very interesting is this, that certainly the global idea with language and using that to communicate about pain is to be what we call very validating. No matter what language you speak, validating doesn't mean catastrophizing with the patient. It means acknowledging their suffering and pain and disability and interference. So it's what I call speaking the truth. It's the yes, and every language can have this baseline. It's the yes, I can see your suffering, I'm here to help. You know, any language you can use, whatever dialect, must start with that, because pain can be very isolating, as I mentioned about how it was very much symptomatic, and now we're recognizing it as a disease. we need to first of all validate. And most patients will tell me, I just don't feel believed, I'm not heard. And in cultural aspects, sometimes they just will suffer quietly and they will not let you know early enough, and then they go to chronicity, you see? So it's being very welcoming about that. If you do speak the local language that you can use with someone, or, you know, with their language type, that creates a better therapeutic rapport. So I would have a less therapy if I came to, you know, South Africa to work, even though I'm some pain expert, I would not be able to deliver in English to somebody, even if I gave the biggest hug and the biggest empathy, I just would not be able to. I would need you, the native speaker, to really do that, you know, and I'll whisper behind your ears, you know. So you're really, if you have that, because that builds therapeutic rapport. And for anybody to want to do anything, first of all, we've got to use trust. They've got to trust you to want to do something. Otherwise, they're like, I don't know if I can trust you. I don't know if I want to do what you tell me. So I think come from those principles, because they are culture wide accepted. You know, they're fundamental, what I call human nature response. They're just part of human nature. No matter what culture, what race, what color you are, that's what I would say. And then use the languages within each culture, each language to, you know, and the other thing with language we have found is narrative, telling a story about the pain, or explaining and we do teach this in terms of pain narratives, telling, you know, how I was explaining about the pathways of pain and the gate theory. Typically, when I'm talking to a patient and educating about that, I'm not talking in the language I gave you. I'm giving them a narrative. I'm giving them a story about how this happens, and I'm giving what we call analogies. So I'm talking about cars, I'm talking about gates, you know, train travel and all that. So use the narrative, we call that, which can be a very powerful way of providing that literacy. I hope that helps.
Amazing, 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 amazing. Thank you so much for that. I really like how you also mentioned that language can be a barrier to creating trust between yourself as a clinician and the patient. And I believe, you know, that therapeutic alliance and rapport is a solid foundation for everything going forward. So it was just interesting to hear how language could establish that or work against such. So thank you for answering that question very comprehensively. All right. And I really like also how you mentioned that when you communicate with your patient, it's not necessary to use medical jargons, as this could be confusing for them, but using simple language, stories, metaphors, and everything could be helpful. And as you were talking about it, it reminded me of a book by Lorimer Moseley, who's Australian as well, Painful Yarns. So Painful Yarns is a very nice book with stories and metaphors on how to explain pain to patients. So I will type it here in the chat. So if you guys would like to read a little bit more on that book, so feel free to do so. It's quite informative and interesting. All right, so let's move on to the next question. So the third question says, what treatments are being used in Australia to treat chemotherapy-induced peripheral neuropathy?
Yeah, that's a really good question, and a very missed group of people, because typically people who go into remission often after chemotherapy, they get almost forgotten about the pain that then creates the life suffering afterwards. So people go, well, you've beat chemo, you've beat cancer, so now, you know, you should be grateful about life and don't complain about your pain. And often we find a lot of post-cancer patients, or even current cancer patients, not, you know, focusing so much on their chemotherapy that the side effects are forgotten, and that makes day-to-day life difficult. So peripheral neuropathy is damage that's resulted from the chemical of the cancer drug. So when there is damage to nerve fibers, whether it's nerve fibers or the bigger nerves, the peripheral nerves, because two things can happen. You can get peripheral nerve fibers, and then you can get the other, bigger nerve pathways, your afferent, your C fibers, A fibers. We will typically use anticonvulsants for treating those on an oral level. So we typically use pregabalin, gabapentin. Both of those are first line. Where I find very useful, and we do it in our practice, is we use compounded topical treatments, because typically chemotherapy, peripheral neuropathy is very condensed to one part of the body only. Typically the feet, can be the hands, can even be face, so peripheral neuropathy is not always what we think of just feet. You can get parts of, it's usually no more than an A4 size that affects the area, wherever the area might be. So we use anticonvulsant treatments at the appropriate doses. Sometimes we will add some tricyclic antidepressants if needed. And I find that if oral treatment is not conducive, then we will actually use compounded treatments to help that. And when I say compounded treatments, we use things like combination amitriptyline with lignocaine. We sometimes use ketamine with lignocaine. These are certainly more in the, advanced pain management space. But we do find that they are, but there's, if you go and read up on topical analgesia, and we do teach this in our program as well, you do actually find that this is evidence-based, though they're not commercially available products, because not everything is commercially available, but we can get around things this way, and it is evidence-based management as well, just to give patients options other than oral treatment.
All right. I told you, that there is so much interest here because questions keep coming and coming, but I'm afraid that we might not have enough time to address every question here, since we still have another part to this presentation. So I'm just going to pitch these two questions to you. So please answer them as briefly as possible, and then we'll move on to the next bit of the presentation. All right, so the second last question goes, neuralgia post-shingles, what treatments do you use on your side of the world? Yeah, so what treatments do you use
Very
for
similar
with neuralgia?
Yeah, very similar to what I talked about with peripheral neuropathy, to be really honest. Very similar. Pretty much those things that I talked about. Potentially some anti-inflammatories to be thrown into that if needed. Again, if there's an acute tissue involvement, but usually that's very short-lived. Yeah, very similar treatment to peripheral neuropathy.
Nice. All right. So last question. What is your opinion on the use of antidepressants such as duloxetine for the off-label treatment of diabetic peripheral neuropathy?
Well, depending on what country you're in, we have ours no longer as off-label treatment. In our therapeutic goods administration, our guidelines allow that, and so evidence-wise, it is very evidence-based to be used for peripheral neuropathy, yes, depending on your guidelines and your funding, allotments, but I have no problems with the science of it. It is strong science on the use of that. Again, the dose, but we're not necessarily treating depression with duloxetine. If you need it to treat depression, your dose may need to be quite a bit higher, into the 90 milligrams. But if you're treating pain alone, doses tend to be more around 60 milligrams. If my patient is suffering both, I tend to find that those are the guys that may tend to sit around the 90 milligrams mark. But the higher you go, the more side effects, so be very careful on that.
Yes, awesome. I think I should throw in one of my questions here. The others will discuss outside this presentation. So I was really interested to see the many areas that pharmacists are involved in: research development, community hospitals, emergency care, so on and so forth. And you also mentioned that it is very important for pharmacists to collaborate with other healthcare professionals. I strongly believe in such collaboration because there is strong evidence showing that pain can be best managed using an interdisciplinary approach. So I'm just interested to know, who are the healthcare professionals that pharmacists can closely collaborate with to improve pain outcomes in our patients?
That's a great question. But physiotherapists to start off with, definitely, because typically function and disability goes together. So if someone is starting to suffer, it's because their function is suffering. They just can't do what they're supposed to do. And then that cycles down in the vicious cycle. So I think a physio is definitely the first port of call, because then your medication regime can support the function aspect, because typically people will fear movement. So if things were aligned well, that's useful. So physiotherapists, I think, is very useful. Here we have exercise physiologists, which is a similar sort of more like an assistant to a physiotherapist. Definitely psychologists. You need to align with psychologists because of the psychosocial, aspect of pain in the limbic system. Together they're very powerful. I mean, if that's all you had in your, say, community setting, that's a really good start. The rest, like occupational therapists and, social workers and all the above, dietitians is also wonderful. But I think pharmacists can sometimes, not to disregard the expert area of dietitians, but that kind of self-care education sometimes pharmacists can use if you don't have access to a dietitian. It's very good to do for some patients who are intolerant of certain foods. However, that's probably, not the priority so much. Not trying to disregard a dietitian's expertise, but I would say if all you had was a psychologist and physio, I think they would be the first to collaborate with. And of course, the GP to keep it inclusive, and always the patient. But definitely, I think the physio and psychologist is very important.
Perfect. I'm really glad that you mentioned a physio, a GP, and a psychologist, because at a primary level of care, these health professionals are strongly involved. So yeah, I'm really excited to see such collaboration forming and growing here in our country.
Yeah, and can I add for pharmacists to go and let them know what you do, because often they don't know what we do. They don't often go, oh, well, what's a pharmacist? What can they do? So if you, even if you've got TENS machines that you can educate them on that will modulate, you've got heat packs. Oh my goodness, the science of heat therapy in pain is just amazing. And how to use it properly. It's not just 20 minutes on, 20 minutes off. There's so much power in using that well. I mean, of course, we teach more about that in our program, but the truth is, please go and tell them what you are about as well.
Yep, absolutely. Wow, this is so interesting. All right, I don't want to get carried away because of the limited time that we have. All right, I think I can safely say we can move on to the next segment of this presentation. So yeah, all to you. Please do continue.
Okay, thank you. I think I'm still sharing screen. Okay, so this brings us to the next part, which talks about the PainWise Professional Service Program. What I gave you was just a snapshot, hopefully, of why education is so important and all the things pharmacists can potentially do if our knowledge was really up there with it, so that, I can clone more of me and to keep that going and to scale it so that we can reach people in your world. So I then became, from all my learnings, my organisation, PainWise, was born. And the mission of PainWise is basically to improve the life and quality of people burdened with pain in the community. And we believe that the access of pain management is a fundamental human right. And so what we've done is we've developed a proper accredited pain management program. It is actually surprising to me. It was actually the first ever pharmacy professional service program in the world, I believe, that was targeted for pharmacists and the unique setting of pharmacists. So I'm not claiming that we were the first pain program in the world, absolutely not. But pharmacists, we've got to admit, in a community setting, particularly, and even in a hospital setting, but more so in a community setting where a big majority of pharmacists are, is a unique setting. It's a commercial setting, but it's also a clinical setting. I don't know in the audience today how many are from community as such, but if we're talking about primary care, then I would assume that you are based in a community setting. So what we did was we provided a clinical program that, you know, had the evidence-based information, was well researched, it's up to date, and it had strategies to help pharmacists to have then the tools to implement. So as I said, one thing about clinical knowledge is to have clinical knowledge, but then what do you do with it on a day-to-day process? So as part of this program, we have not only provided a 10-hour education program online, which is how you access it, but we've also got resources, clinical and also collateral resources that you can use to then activate interventions for your patients. So for example, disease state care plans, well, we've got the formats, the templates that you can use so you can grab and go essentially. Because when I was working in this space, even as a pharmacist, and then later on in developing programs, I realized that one thing was to teach you, but the next thing was to go, oh, what do I have to put together to give my patient at the point of interaction? And usually there was a real deficit of what was available there. So what we've done is we've created those resources that was pharmacist friendly for the use of it in a pharmacy setting, not for the use of it in a tertiary clinic setting, which certainly has its own type of resources, but for community pharmacy setting primarily. It can be used in hospitals as well, but it's got that pharmacy focus. So what we've done, we've trained pharmacists across Australia. And what we've also done is we've understood, of course, the unique role of pharmacies and how easily accessible it is. So then we put pharmacies on the map, on our training map, so that, or on our website map, so that patients could then go and look for these pharmacies that were aligned and trained in pain management. And on average at the moment on our map, we get about 25,000 hits monthly of patients looking for a pharmacy to go to where they can have good conversation for pain management. They want to be validated, they want to be heard. So we've trained pharmacists to be able in this space, and workforce capacity has increased as a result of being able to provide better pain management solutions to patients. So in terms of our programs, we've got our foundation program. So this is all the things that teach us. Pain science, the pharmacology, nutraceuticals, which is the supplements, evidence-based supplements that can be used, because not everybody wants to have a prescribed drug. Some of the questions you guys asked before, we spend a lot more time explaining about those things. Opioid rationalization, you know, how do we reduce opioids? How do we think about opioids? How do we discuss opioids? Looking at care navigation. Now, this is where we have resources in terms of these key disease state management. So that if I'm looking for someone to manage their back pain, there's a template of all the evidence-based things that I can recommend. So it's almost like a pre-populated sheet that you can use almost as a prescription pad almost, so that the patient lives with a plan. And these disease state plans, even though they are pharmacist friendly, we are also promoting collaboration. So on the plans, it also allows the pharmacist to remember, okay, who can I collaborate with? And there's sections in the plan that sort of condenses that, so that if you now go and make friends with the physio down the road, you can put his contact down, and now the patient has another team member that they can potentially contact. We look at motivational interviewing because that's part of that language of pain. Of course, you know, in the cultural context, you will then adapt that. Then we look at, so all of that's fairly clinical. Then we look at how we create the commercial aspect. How do we turn that into a valuable service? How do we create value for the patients who want to come to us to perhaps spend some money for this service within reason? And we also have our, what we call our commercial program, which is our 1 extra degree program, which you get access to. So this is then helps the implementation of the disease with the science. As a pharmacist, when I go for education for a very long time, I used to get a lot of the clinical stuff. I don't think we're honestly always short of that. We get a lot of that. But one of the hardest things I found, both in myself and also in my peers and in what we heard in feedback, was, okay, how do I implement this? How do I make it so that then it's commercially valuable, that I can then spend time doing this with the patient? So this tries to provide you with some of the concepts of very simple 3 areas that it looks at with the 1 extra degree program, which you have access to. If you really like pain after that and think this is really cool, then you can go and do our advanced program, which is another 10 hours. And that gives more specific targeted disease state pathophysiology areas, looking at some of these key disease states that are here. And it also looks a little bit more in depth with things that pharmacists do supply and sell, things that are non-pharmacological from a device point of view. So we look at bracing, we look at what's the appropriate use of that, we look at heat therapy, we look at the TENS machine device, we look at other devices that are available, we look at disease state management, particularly tension headaches, migraine. And very interestingly, we look at food and pain. And as I was saying before about the pharmacists and in the setting, you start to find pharmacists starting to, deal with weight management. But in pain, you also start to see patients with chronic pain start to find that they tolerate food less, and they've got sensitivities to food, or they're very fatigued, they're very tired. And how do where does the science of pain, signs of food, come in to help patients with pain? And in the pharmacy setting, this is also something that I think pharmacists are more and more starting to stock in their community pharmacy, but also how do we do it scientifically so it is evidence-based? Because patients are reading a lot about this online and they're being a little bit random, I think, in their, 1 minute it's vegan diet, next minute it's FODMAPs, next minute it's all these intolerances to exclude. So we can play a part in that as well, rather than have them just looking at self-selecting from the shelf. And after the advanced program, you then get, you become an accredited PainWise advanced pharmacist, and we provide a badge that actually, sort of credentials that, so to speak. So there we have our core, which is our clinical. Then we have our peripheral program, which is this 1 extra degree commercial program that you then can do. And as I said, this is very simple. It looks at how do I start? So it looks at the patient journey and how to implement the learnings of PainWise. How do you optimize your time? Everybody's always time poor. So it looks at how you can, strategically optimize your time and what you do as a pharmacist. And then, of course, how does this look like from a commercial aspect? Because services have to be sustainable, and how you can creatively offer that as a service offering and create value. And of course, beyond that, have relevance with the patient, because it's not like access into, pain clinics are that available. So we do become a very affordable resource when you look at it. And we have a tool there, which is a revenue multiplying tool that you can use to calculate what you potentially could earn from a service as well. So that's really a snapshot. Kat, I think we've got some questions. Oops, that's how you connect with me if you want to, so feel free. But I think you've got a few more questions about pain-wise in terms of, you know, how,
Yes.
from your setting.
Yes, I have a couple of questions that I've noted down here. You know, through our interactions, I know the answers to some of those questions, but I thought it would be helpful for me to pitch these questions again to you, so that those who are in attendance would know as much as I know. So the first question that I have here is, when did PainWise first start?
Historically, it started about in 2010, so almost a good 11 years ago. And it started because there was so many questions coming to me about pain management that were repeatedly showing that there was a really lack of understanding. So we started to provide, you know, obviously research education on it. And where it started was because of, in our country, the opioid overuse. And that's where it kind of started in going, how can we provide better monitoring, compliance? But then, of course, as you open a box, you open the next box and you start to realize that there's so much more in pain management and understanding it. And there's so much more that we can do.
Nice, interesting. So there is a clear indication that you and your team have been doing this fantastic and very important work for some time now. And I'm really glad that that is the case. So you've mentioned that when we were having a chat a while ago, the outline of the program. So I'd really like you to share with our audience today, like, how is the program conducted?
Right, okay, that's a good question. So I've put up here just our main website, which sort of basically shows, you know, what we do and the training aspect, which is here. We also have some other community relief project that we do as part of our philanthropic work, because we like to put, you know, our especially our words into regional areas that miss out on care. When you register to train, you actually don't come to this main website. Through this main website here, you actually collect all the brochures. And once you are a member, you log in and you can get your brochures from here. And in Australia, you'll see that, and New Zealand slowly coming on board as well. But in Australia, you'll see that we actually have the pharmacists kind of listed here on the map. So so that's where the 600 pharmacists come about. As you can see, we've actually trained Australia wide over all this time, even in some sort of nearby islands, I think. So this can be certainly created for South Africa. There's no problems there because patients, we're not a product seller, you know, so we're very, very open to all kinds of evidence-based products. So when we highlight our website, it's purely for navigation. So patients can go and find someone who can help them, and it's preferably a trained pharmacist. So this is our main site, where behind this in the members area, you'll get all your brochures and disease state care plans. In a different website is where we register in for training, where you will do your video-based, it is video-based, 10 hours of training with case studies, with multiple choice questions, and the ability to interact with us so that we can help you even implement it. So after you actually train, if you're like, okay, great information, I'm still a bit overwhelmed, can I make an appointment with you to think about how I can apply it in my setting? That's totally fine. And we provide that mentoring, in unlimited mentoring. If you want to call us 10 times a day, you can. If you want to email, obviously more email us, you can. It's quite unlimited, because I found also through all our work that everybody needs a coach and a mentor to do some of this stuff, especially when it's new. And it's really important to handhold it, particularly in a different setting, so we do provide that. Yeah, so that's essentially what happens. You register, very simple, you watch through videos, you do some case studies, and a lot of the education also tries to use material from this main website, so that it's not like see the resources and go, ooh, what do I do with this resource? Especially our disease state care plans, it gets you to use it there in your case study activity.
Wow, 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 wow. I see this as not only a very good learning tool for pharmacists who are interested in pain management, but also as a platform to foster collaborations between pharmacists, pharmacy practices, and pain wise. So I really like the detailed map of Australia here. It would be fantastic if we have something like this in South Africa. So all the pharmacists who are here and those who own their individual private practices, feel free to stay in touch with us so that we can make this a reality together. All right, so my third question that I have here is that I really like how the website is outlined, the interface, and it's really user-friendly. So you mentioned that there is a training platform to this website. So I just want to know, how long does it take to complete a program?
Yeah, so it's all very self-paced because we understand that people are all busy at the moment. If you pace it quite, consistently in terms of the minutes of videos there, it's all about 10 hours end to end. So that includes study completion, and that also includes your multiple choice questions, and there are 15 multiple choice questions. So obviously end to end, it's about 10 hours. Of course, if you take a bit longer with case studies, that's fine. And that, you can pace those 10 hours if you want to do an hour a day, or, what we have is also, we've got the breakdown of how many minutes each video is. Before, how sometimes you watch a video and then you're like, oh man, it's like 30 minutes. If only I'd known, because I only have 10 minutes. So it shows how many minutes it will take for you to listen to a certain module. So then if you listen to that and you're like, great, I've got 10 minutes, I'm just going to do that 10-minute, great. So it's sequential. It's a module after module, and you finish it, then you go to the next one. But it tells you how many minutes. So therefore you're prepared and you can fit it in to your schedule. Oops, hello.
Did I lose you for a second there? Can you still hear me?
Yeah, I think we froze for a minute.
Okay, that's probably me. Anyways, let's continue. I really like how the whole module is self-paced, because we all have responsibilities, family, work, and all of that. And if we take things according to our pace, then it makes learning a bit more fun and sustainable in a way. All right, so moving forward, I have the second last question that I have here. So upon completing this program, how do you get your certification?
It's all automated. So if you go and complete all the case studies and the MCQs, really right down the very end, it'll trigger a certificate. It is accredited in the Australian setting with our Australian Pharmacy Council for 10 CP points. Now, how that translates in your setting, I'm not sure. But certainly we can look through that, work through that, and certainly if there's an interest, if there are local accreditation bodies and things like that, we would be more than happy to, create that. In some other countries, like for example in New Zealand, which is probably more similar to Australia, they, one group 1 point equals 1 hour. So typically in some boards of the bodies that legislate this stuff, they sort of go, well, it takes you 10 hours, so therefore that's 10 points. But Australia setting is a 10 CPD activity.
Yep, we use pretty much the same format here. So I think it's something that we could get accreditation for here in South Africa. Interesting. And also because as healthcare professionals, we are required by policy or law, if I am correct by saying so, to get CPD points on a yearly basis. So I think this would be a very good tool for South African pharmacists to have. All right. So my question, another one, is that aside from the registration into the PainWise Foundation program, does PainWise provide pharmacists with other resources?
Oh, yes. So as I said before, at our main site here, once you're registered into the education part and get started with that, probably one of the first things it does is lead you to register to this main site. And once you've got your login for this main site, then this will, which sort of occurs here, this will then access you to the different brochures and collaterals that you can already start using. You know, brochures about acute pain or chronic pain, or how to talk to your healthcare professional about pain, a disease state management tool. Of course, when you start to go through the training, you start to be able to use more of the materials more meaningfully. But certainly you can get access to that, and it's all part of the part of the provision as such as well. So the pharmacists will come here to register for that, and then access will be given, and then you just log in there. So they come and register for all the collateral materials here, and then you get access beyond that, and we know that you can access the information as well. Yeah, so that's very easily done. Can I also add that with the learning platform, we give 3 to 6 months to complete as well. So again, with busy lives, it's not a strict thing. If pharmacists get a bit challenged and of course, the sooner the better, because it's all fresh. You don't want to watch 10 minutes and then not watch it for another few months and then remember it again. That makes learning a little bit less effective. However, if things happen and you need us to extend your timing, then we certainly can. Yeah, we are here to make sure that pharmacists are learning it in a method that suits them, but also a way that they can implement.
All right. Interesting. Seeing that we're getting closer to the end of our presentation, the last question that I have is, besides this exciting work that you are doing with PainWise and pharmacists all over the world, what are you involved in more broadly?
Well, I basically I'm involved in education in this format broadly for different stakeholders. But I'm also locally, I also manage the pain clinic here, which is which attracts basically government funding. It's a very specially designed primary health pain clinic. It's actually the first in Australia in a primary health setting, because typically pain clinics are always through a hospital setting. But the road in is very narrow and everyone's jamming up at the same door. So what we did was we designed and proposed to government and then piloted about 7 years ago now. So we've been in operations for 7 years now. I also direct the pain program there. And I suppose that's, coming from a pharmacist background, that is the evolution of how a basic pharmacist career can actually go into so many areas. Unfortunately, I just don't have any precedent in some of these areas. So a lot of it has been uncharted grounds. But I suppose being an innovator, you don't fear that, and it's a curiosity. It's like a curious cat going down a channel and scurrying from side to side, going, "Ooh, what if we tried this and what if we tried that?" So I suppose I do that, and then I give a lot of my time also philanthropically, which is 50% of work is commercial, 50% is philanthropy, whereby a lot of that is focused on planting pain services in regional areas of Australia. areas in Southeast Asia where they cannot and literally will never get access to pain services. So they're more on a voluntary basis. And we've actually got our online patient Conquer Your Pain program that we've actually recently launched. And that's actually, if anybody's ever curious, that's actually the community aspect of this part of our website here. That actually is our philanthropic arm here, and I spend a fair bit of time planting those services in different parts of Australia at the moment as well. So that's letting community have something in pain management, and these patients actually they do pay a membership fee, but they do access our online pain program. Yeah, so that they can learn more. That's been quite new, actually. I don't think I told you much about that the last time we spoke, because that's only been quite new. So those things busy my days.
Wow. So you really are involved in many things. Before I continue with my commenting here, if there is anyone that has a final burning question, we have about 5 minutes to wrap up. So please do send it in the chat so that we can address it. But really, Joyce, I really appreciate you. Let me just start first by saying this. I really appreciate you taking your precious time to come and share your knowledge and just pour your understanding to all of us here who are in attendance. And what really makes this more special is that you are one of the leaders in your field. We aren't just learning from anyone here. We are learning from an expert. You know, you've been doing this thing for a very long time, and really we trust your knowledge and the credibility of the work that you are doing. Moreover, it's literally Thursday in Australia as we speak. Am I correct? It is Thursday morning, isn't it? Yep.
Yes,
so we're looking
4 a.m.
Just 5 minutes
4
before 4 a.m. And here we are in South Africa. We are still Wednesday, just before 8 o'clock. I really appreciate you sharing your knowledge with us in the early hours of the morning when most people around the world are sleeping. All right. So to all the people who are in attendance, I'd like to appreciate you also for joining us. I hope that you have learned as much as I have learned. Goodness me, I'm not a pharmacist, but I really wish I was one at this moment. And I'm really excited about all the knowledge that I have learned today. So if you'd like to reach out to us and you'd like to learn a little bit more about PainWise, the program that Joyce has introduced over the past few years, feel free to connect with her on LinkedIn. All right. So Joyce Maxwan, the name is right there. Go to LinkedIn, search for her name, and then connect with her, and then take it further from there. Or alternatively, you can just go to our website or use our email, painandbrain@icloud.com, to just reach out to us. We will forward her your message. I think she's going for that final slide with the contact details. Yeah. All right. So here is the information. If you are connecting from your laptop, just take a photo of it. If you are connecting from your phone, just screen grab it and then reach out to us. And I really like how this information is balanced. All right. So balanced in a sense that the information helps us to provide holistic care that improves outcomes in our patients. But it also acknowledges that the commercial side of it, because running a pharmacy, it is a commercial, it is a business, overall. So while we provide care, how do we maximize the commercial aspect of it? And I really love how everything is balanced out. So nice signature over there.
What have I done? Sorry.
Don't worry
the scribble
about
on
it.
The screen.
Yeah. So I really like how it's balanced. So it really covers people who are in the clinical side of pharmacy, but also who are in the commercial space in pharmacy. So if you'd like to collaborate, And if you'd like to get more information from Joyce with regards to establishing yourself and perhaps collaborating with PainWise, I strongly encourage you to reach out to her via LinkedIn or email her or use any of those contact details displayed on the screen. And as for us, Pain in Brain, we bring you the best of the best, trying to inform all healthcare professionals in South Africa about pain management and new research that is out there. So please do go to LinkedIn and follow us there for more updates. And lastly, and most importantly, this webinar was presented free of charge. And the reason is that Aspen PharmaCare sponsored each and every individual who is in this webinar tonight. So a big shout out and a big thank you to Aspen PharmaCare for sponsoring us. We hope that they will continue to support this great initiative as we go forward. All right, guys, we are just 2 minutes away from 8 o'clock. I won't hold you hostage. Thank you for joining us. A final reminder, reach out to Joyce to learn more about this and follow us on LinkedIn in Pain in Brain. And I will close this meeting for tonight. Any further questions or any feedback that you'd like to give to Joyce with this few minutes that's left? Going once, going twice, and I'll just close it there. So for any direct feedback, feel free to email us. We'll pass it on to Joyce. All right, guys, have yourself a wonderful night and stay in contact. Bye-bye.